So,
to be honest,
Dr.
Dr. Kilidireas is not there are some connection issues, and unfortunately, he cannot be with us. So we will move to the last speaker, who is coming from the extraordinary Mexico. It's Dr. Sierra-Galan, the head of cardiology at Santa Fe campus of the American British Codray Medical Center in Mexico City, and she is going to speak about cardiac MRI in female diseases. I think Dr. Sierra is the most appropriate person in order to speak about women, about females, and I'm very glad to be in the panel among three women, Professor Angeli, Professor Maurogeni, and Dr. Sierra. So the microphone is, let's say, open, and we can, let's say, just appreciate and hear your excellent speech. Thank you very much for joining us.
Thank you. Thank you for inviting me. And I'm going to share my screen. I think it's there. And do you see my presentation?
No.
No? It's shared.
Yes.
Your screen.
Yes?
Yeah, it's shared. Yeah, it's ready.
Okay, you see it. Okay, so thank you again for inviting me to participate in this meeting. And with the previous comments, I think I have the perfect introduction because it's not only to include cardiologists, but it's also to include women in the field and to study women as patients. So with that, I would like to start with the presentation about CMR in female diseases. And this is the agenda for today's talk. And the first thing is why females. So the main thing is that women are underrepresented in clinical trials. This is slowly improving, but it's still clearly underrepresented. So we need to focus on that because it's understudied, unrecognized, underdiagnosed, undertreated, and basically underrepresented. And most of the women that are included in the clinical trials are postmenopausal. So we have a limited numbers of sex-specific and age-balanced imaging and management guidelines for women with cardiovascular diseases, and it currently is the main cause of morbidity and mortality worldwide. So we need to do something about it. The strategies to increase the proportion of women in cardiovascular trials are several, but mainly we need to be inclusive. We need to exchange knowledge, as Sophie mentioned before. We need to make networking, and we need to remove barriers. And for this, we have different strategies in all these subgroups, so we need to work on that. And we have to be aware that woman has biological and hormonal differences, and those differences we can't divide it into different groups. We have sex influence difference and risk factors for cardiovascular diseases in women, such some factors that are unrecognized frequently. Not too many healthcare and the primary doctors are investigating for these risk factors, such as early menopause or gestational diabetes or hypertensive disorders of pregnancy or other problems during delivery or gynecological issues. And other under-recognized risk factors are the psychosocial risk, the abuse, and intimate partner violence, socioeconomic deprivation, poor health access, and the environmental risks, and all those specific risk factors for women are in addition to the traditional risk factors such as hypertension, obesity, dyslipidemia, diabetes, etc. So we need to think different when we are in front of a woman, because not only for those risk factors, but also because woman has anatomical difference. Women have a smaller heart, so we need to think different. Um, we need to consider that our measurements, the LV, the RV volumes are slower, are smaller. The ejection fraction is larger. The left atrium volume is smaller. The emptying fraction is larger, and the same for the right atrium. So we need to uh, analyze and study women in a different way. But it's not only related to those, it's also in terms of tissue characterization. We have a difference in tissue values and tissue star values. We also have higher native tissue star and higher native T1 value and extracellular volume. Uh, so we need to individualize our cohorts depending of the gender, and not only age, body mass index, or height and weight. The most important problem is ischemic heart disease, which is also the main cause of death in our country and in the rest of the world, in women. But in women, we have a typical presentation, which is more common than in male. We have a more prevalent microvascular angina and MINOCA. Uh, for a woman, stress perfusion is an advantage because we can identify microvascular dysfunction, and we are not using ionizing radiation. And we can differentiate ischemic from non-ischemic injury. So, in addition to the differences that we already discussed about anatomy and risk factors, we have a difference in myocardial infarction. Women usually present older than male, and usually the outcomes are worst because woman has subclinical damage, chronic subclinical damage that make that a woman has a higher risk in almost all aspects. If you see these plots, you will see that the higher risk for women is in all areas, is independent of the health model. You are going to have more all-cause mortality, more cardiovascular mortality, more incident cardiovascular events, more recurrent MI, worst outcome of MI. So we need to be very focused on women's health and the risk of cardiovascular disease, because also this female has a risk that is higher for heart failure and mortality after an acute myocardial infarction. So we are dealing with a serious problem that, as I mentioned before, is underdiagnosed and under-recognized. in the and related to myocardial ischemia, we have the current validation for stress perfusion imaging, as you can see here. There's a lot of literature that support that CMR should be the test of choice for myocardial ischemia. Is superior to nuclear techniques, and with the better diagnostic accuracy in women, and it is in a real world population, it shows that it's not inferior. And in long-term analysis, we see that using CMR perfusion as a gatekeeper is a safe strategy, and it is not inferior to the current recommendations of the guidelines, such as functional analysis of the plaques as an invasive imaging or FFR. And at the end, this technique allowed to do less intervention, which is favorable for the patient and for the healthcare economics. So we should do more myocardial stress perfusion in everyone, but mainly in women. And one of the main roles of CMR, which is actually right now a class 1 indication, is MINOCA, which is one disease that is more prevalent in women than in male. And MINOCA has right now to be evaluated by a cardiac MRI. It's not just a recommendation, it's a must. Because with CMR, we can differentiate MINOCA, the real MINOCA, for the other type of presentations. And also, we already know that MINOCA has a worst survival. So we really need to be very rigid in try to identify the cause of the problem, because it is already described that is we perform CMR later than 14 days after the trigger event. We are going to misdiagnose the cases as normal, because with the time we are going to be losing the theology and the diagnosis, which is going to be a problem for the patient because of this increased risk of subsequent events and the risk of MACE in those patients with MINOCA, and mainly in those that are not properly diagnosed. So the current recommendation is to have CMR done before 14 days, ideally between 17 to 14 days max. And with that, we are doing something for this disease and for women in general. So with MINOCA, we have CMR playing a key role because we have LG patterns that are very precise to identify the cause. We have myocardial edema techniques, we have mapping, T1 and T2 mapping, and we can know the extracellular volume. And also we can identify macrovascular obstructions. And we can identify the prognostic markers such as the LG extent, the edema, and the presence of microvascular obstruction, which is different depending on the cause of the MINOCA. And this is very important because women has higher prevalence of myocarditis, Takotsubo, and microvascular dysfunction. And for example, as is shown in this plot, we can see that a patient with a cardiomyopathy or with a Takotsubo cardiomyopathy has higher mortality than those that don't have it. So it is very important to do a CMR, do it in the first 14 days maximum, and to identify the cause. So the CMR, as I mentioned before, can distinguish between the patterns of ischemic and non-ischemic injury, and that allows guiding therapy and prognosis. So the first thing is to rule out MINOCA, which is important because of this difference in cardiovascular mortality and morbidity. And if we rule in MINOCA, in to differentiate the different types of MINOCA. So for that, CMR has a specific and very important role that others technique cannot do. Now let's move on to the next problem, which is the cardiomyopathies. The first cardiomyopathy that is a big problem in women is a dilated cardiomyopathy, and CMR has a key role here. This disease or this cardiomyopathy usually present later in women with more advanced symptoms, and here CMR can identify a hallmark of risk, which is the mid-wall fibrosis, being an important predictor of arrhythmic risk. So this is very useful information for risk stratification and to guide the device therapy decisions and ICD implantations, etc. Now let's move on to hypertrophic cardiomyopathy. And in this, well, CMR has less cases than males. As you can see here, we see more often male with hypertrophic cardiomyopathy. I hope is because of the prevalence and not because it's underdiagnosed in women. So in this case, CMR can identify the risk markers of HCM, such as the presence and the amount of LGE, and others like the wall thickness and the degree of obstruction, the presence of apical aneurysms, etc. So this is very important because, as you can see in these images, the woman has greater mortality for similar stages of the hypertrophic cardiomyopathy, and are more likely to have an obstructive physiology. So we need to do this as earlier, because this study is usually done later in women when they are clearly symptomatic, and not as in men, which is done earlier. And now let's talk about arrhythmogenic cardiomyopathy. And here again is more prevalent in male, but even if it's less prevalent in women, a woman has higher risk of heart failure progression. The LV is more commonly involved in women than in men, and pregnancy is a problem because this can be present at the age of a woman to get pregnant. And it is usually well tolerated depending on the stage of the disease and the severity of the disease, but there is an increased risk of arrhythmia, mainly in late pregnancy and postpartum, and the progression is similar, but the woman has more tendency to develop heart failure. Now, the restrictive and infiltrative cardiomyopathies. Well, first, cardiac amyloid has different presentations, as you can see here, between male and females. And females usually have more neurological symptoms than male. And uh, in this presentation, where is predominantly cardiac or with heart involvement, is more prevalent in male than in female. Um, uh, so we need to think in this disease also. And this cardiac amyloid is more prevalent, the AL type, in women, and with worse prognosis than ATTR, which is more prevalent in men. In women, there is more subendocardial and transmural LGE, and the ECV is higher than in man. So we need to think in those concepts before make a conclusion in the diagnosis. And now the cardiac sarcoid. Um, we have problems with cardiac sarcoid because it can simulate other diseases. The LGE, as in other diseases, could be mid-wall and subepicardial. And in women, we have less ventricular arrhythmias, and the ICD implantation is less than in man. And the problem is that the mortality in hospital is higher than in man, as in other diseases or cardiovascular diseases, even if the lower prevalence of the ventricular arrhythmias. So we need to be more cautious about sarcoidosis in women and make the proper diagnosis, because we usually don't think in this disease in some environments, and the endomyocardial biopsy, as in the rest of the world and in other diseases, is being used less and less, and it is even less in women. Now, the stress cardiomyopathy, the Takotsubo, this is more frequent in women and is more, it's a cardiomyopathy that is more considered in women. This is something that is usually a thing that is only related to emotional stress, but there is other factors in women, such as non-obstructive coronary artery disease, that could be triggered for different reason, most frequently than in men. And we will have this Takotsubo presentation. Actually, being male in this disease is a more adverse predictor of events. So we can say that we tolerate more stress, and we are giving along this disease better than male. Um, so we need to do CMR because the diagnosis, as you can see here, is no LGE or minimal LGE that is described in some series, but mainly the different type of ballooning of a left ventricle. As you can see here, it could be the typical apical, the mid ventricle, or the basal one, and the presence of edema, the myocardial edema, which is one of more uh, solid and more robust methodologies of CMR. We can see very clearly the myocardial edema in all the cardiomyopathies. And now let's talk about pregnancy. And pregnancy is first of all is the safety of CMR in pregnancy is something that it's currently validated. We can do CMR. Is considered safe across all trimesters with non-contrast CMR ideally. There is no evidence of teratogenicity or adverse neurodevelopment outcomes. Usually it's preferred at 1.5 Tesla, but it could be done at 3 Tesla, and it's safe in observational cohorts. The problem is the acoustic noise. We need to protect the mother as for the same for all other patients, and it's not proven that there is fetal hearing damage. And the recommendation is to try to limit the exam duration. Related to the contrast use during pregnancy, as you can see in this schematic, gadolinium crosses the placenta and is transferred to the fetus. So we should avoid the gadolinium injection. And if we need to use gadolinium because the diagnosis with the contrast is overweighting the risk for the fetus, then we need to use microcyclic agents such as all the currently available chelates. So we use these microcyclic agents and with the lowest dose possible. And the recommendation is to use it only when results are expected to change the management. Otherwise, it's preferred to avoid. And all the time for these specific scenarios, we should have a multidisciplinary discussion between cardiologists, radiologists, and obstetrics. Thinking all the time in the safety of the binomium, the mother and the baby. Then the peripartum cardiomyopathy, which could be from the beginning and all the way down to the first month of postpartum. And the definition is a non-ischemic cardiomyopathy with reduced LVEF less than 45%, which is commonly present in the first months of the postpartum or towards to the end of pregnancy. The prevalence of very low is around 0.1% of pregnancies, but it has a high morbidity and mortality. It could be as low as 7%, but it could be very high as 50%. There are some risk factors that increase the risk of presentation of a peripartum cardiomyopathy. And the problem is it's often misdiagnosed, which produces a delayed treatment and increases morbidity and mortality. The findings are LV dilatation and systolic and dysfunction. We can find different patterns of LG, subepicardial or mid-wall fibrosis. And if the LG amount is higher than 40%, then we have a worse prognosis, and a myocardial edema can be present, but that depends if we are scanning the patient during the acute phases. And the most or the only significant finding is among all the CMR findings that we could have, the regional wall motion, the edema, the LG, the increased trabeculation, the pericardial effusion, LV thrombus or pleural effusion. All those parameters are non-significant when we adjust statistically, but the only one that is a marker of a risk is the RB involvement. The clinical implications, well, we already say that it's a worse prognosis if we have a 40% or higher LGE, the slower recovery of this disease, and the higher recurrence of this complication in future pregnancies. So the recommendation is to have counseling and obviously to use CMR for risk stratification for future pregnancies, and to monitor the fibrosis and the persistent LV dysfunction. So now a quick review for the autoimmunity, because this is extensively covered in the program. We know that the woman has higher burden of autoimmune disease, all different type of autoimmune diseases. That CMR is the queen to distinguish inflammation from fibrosis, and we can use the different sequences, the T2, the LGE, the T1, the native T1, the extracellular volume, to characterize the tissue. We can get prognosis depending on the extent of the pattern of LG and the amount of ECB. And with that, we can guide therapy mainly when echo is inconclusive. And specifically in this autoimmune disease, ideally we should have it in all disease, in all autoimmune diseases as early as possible, because it's already described that it changed the management and the MACE and the outcomes of the patients. But up to date, we should do it if the patient has a MINOCA, a new heart failure, suspected myocarditis, unexplained arrhythmias, or when the patient is considering to get pregnant. In the setting of lupus and antiphospholipids, when the patient has chest pain and the troponin is normal coronaries with troponin rise, we should do CMR, and then we should differentiate the ischemic-like pattern and the myocarditis and vasculitis patterns, which is going to have a clinical impact in clarify etiology, avoid unnecessary cuts, to guide anticoagulation versus immunosuppression, and to guide the patient through a pregnancy situation. Then for systemic sclerosis, we have to differentiate mainly between microvascular injury and fibrosis. The hallmarks of this is the use of stress perfusion, as I mentioned, is a very robust technique and is not using ionizing radiation. We can see the diffuse fibrosis either with LGE or even earlier, when it just increase in ATT1 and increase ECB, even without the or before the presence of LGE. Then we are going to see the patchy LGE with the insertion points and the mesocardial. Remember the risk or the increased risk of the mid wall in the anteroseptum. And we should scan these patients when this patient has symptoms, increased BNP, abnormalities in the EKG, or again, we are counseling for a pregnancy decision. And the problem is that usually the conventional CMR is normal, and only 34.5% of these cases has abnormal mapping. So we need to consider all these facts when we are addressing the systemic sclerosis. And finally, the arthritis, where we are going to look for subclinical myocarditis, which is the most common thing. And the CMR findings is the myocardial edema and the diffuse fibrosis with the increased native T1 and the increased ECB, even in the setting of absence of different patterns of LGE and with normal ventricular function. So we should scan the patient when this patient has persistent dyspnea and the other causes are not relevant, when we have a increase or alter biomarkers, abnormal ECG, or when we decide to do a baseline CMR study before using the biologic treatment. The future perspectives are very and I'm enthusiastic about the future because of the emergent role of mapping in female specific diseases. There is increased number of women in all studies and clinical trials, and there are longitudinal studies in specific women cohorts, the personalized medicine, and the inclusion of AI and the integration with cardio-obstetric programs. So the key take-home messages are: female-specific conditions require tailored imaging. CMR is safe, multiparametric, is a very important methodology that give us a lot of answers. Is radiation free. Is woman, remember, has unique entities like peripartum cardiomyopathies. Autoimmune is a great field for a study in women, and early diagnosis impact prognosis and management and the management of these patients. So thank you very much.
Thank you very much. Gracias.
Muchas gracias.
Muchas gracias. Of course. I mean, it's amazing. It was an amazing presentation, and I really enjoyed it. I have the feeling, I don't know, I mean, you are the specialists on CMR, that women are underrepresented in several studies, CMR studies, and they are under-referred to the specialist in order to have a CMR. Because of, I mean, there are different barriers from country to country and from, let's say, from city to city. I'm just wondering, and I need your, let's say, your feedback here. Do you perform in cases, I mean, because the women have more and more chest pain and angina-like pain. Do you have referrals for stress CMR in these cases? Because there are some studies suggesting that with stress CMR in women, we have less referrals to the interventional cardiologist in order to perform a coronary angiography. Is there, let's say, is this concept, let's say, in Mexico or let's say in your hospital, I mean, to refer the women, I mean, with chest pain, straightforward to stress CMR, or they have to do a stress echo or a SPECT or I know a simple stress test before, let's say, refer the patient to a stress for a stress CMR.
Well, that's an excellent question, and I'm very proud that to say that at my institution we finally changed their mind because after 25 years after I trained, I can tell you that I am seeing the light because before it was a nightmare. They say, "Hey, you are telling us that the patient has something, but the echo is normal. So echo is right, and you are wrong." And the same for nuclear. And they did a lot of unnecessary cuts and procedures, and now it's not. Now they are doing more CMR in patients with the stress or chest pain with normal or even abnormal EKG and with troponin raised. So it is interesting that we are changing their mind, and in women is even more common. I'm think that the reason is not just because we are fighting, trying to introduce these concepts in their mind of and new generations, which is very important because with the old physicians is more difficult to change their way of thinking. They have a routine and it's very difficult to change it. But for the incoming physicians, I think it's easier. They are understanding the role and the differences of each technique. And the other thing is we have an infart code at the hospital, so we follow those criteria. And if the patient is not going to be in that protocol, then we start thinking out of the box. So that allows us to go to CMR directly. We have access to CMR 24/7, all days of the year. We have 2 available magnets, what 3T and other 5.5 Tesla, and we have 3 shifts of technologists all days, and is next to the emergency department, which is a very important thing because we can have an emergency and feed the patient in each scan. And the other thing is we throw the nuclear scan from the window. So we changed the spec camera for a 3D scanner.
Okay. I think you are very advanced. Professor Angeli.
I have to add a question on this interesting topic on stress CMR. Do you use stress CMR in women who have undergone, who underwent radiation, chest radiation, or chemotherapies, just to diagnose severe coronary artery disease in routine practice, clinical practice?
Yes, actually, we are creating the cardio-oncology department, and CMR is going to be an important part. Actually, last week we have a meeting to make a conscience to the oncologist and to the internal medicine department about the radiation and the importance of having the follow-up of the patients with a non-ionizing radiation such as CMR, mainly in women.
Okay.
The last provocative question, Professor Angeli, it's for you and for Dr. Sierra. Stress echo or stress CMR?
Stress
What is
CMR,
the-
no doubts about it.
It depends on expertise. What is the availability of its technique?
Well,
No,
that's true.
no
If you don't
yeah.
have if you don't have a privileged situation and the availability of CMR for your patient is going to take some weeks or months, then stress echo maybe is going to be the option. I agree with that.
Okay.
Professor Agel is an expert in stress echo. This is, I mean, the reason I'm teasing her. But okay, I mean,
Well, she jumped
It depends on the
immediately to
availability.
defend stress echo, you know.
yeah.
Okay.
So
Okay.
it's nice.
So, thank you very much. So we proceed to the next recorded presentation. Sophia, what do you think? We have,
No, I think, before we proceed, I have to congratulate Lilia for being with us. And she gave us the opportunity to understand that the main problem with women is inflammation in contrast to men, which is ischemia. We are coming from different planets. However, we can find a common way. Thank you, Lilia, for joining
Thank
us.
you.
Thank
and,
you,
and
thank you.
congratulations.
Oh,
Thank
see
you.
you in Rio.
Ah, yes. We'll
Yes,
see you there.
yes,
Okay.
yes. We have fun together.
Yeah.
Thank you.
Okay.
Okay.
Okay.